Hi, I'm Stacy, and this is part 3 of 4 of the review of the thorax and abdomen. So we're going to start with some sort of hard stuff. I'm going to get a laser pointer. Okay. So it's really difficult to talk about all of the nerves and think about the blood supply and then also think about the embryological development like foregut, midgut, and hindgut, and sort of put it all together in your mind. So I've got this one picture that if you can draw this out on your scrap sheet of paper while you're taking your exam, or just kind of go through it and think about it and look at it, it makes a whole lot more sense. So we're going to start with the spinal cord and the spine in general. So as we've talked about, we've got cervical vertebrae, thoracic vertebrae, lumbar vertebrae, and then sacral vertebrae. Okay? So from our cervical, we've got this vagus nerve. Now we've talked about the vagus nerve. It is a parasympathetic system, like we've talked about. And then the other parasympathetic nerve is the pelvic splanchnics. And so we said that it was the parasympathetics were in the cervical spine and the sacral. And from the sacral, the pelvic splanchnics come S2, S3, and S4. And so that's important to remember those levels. We said that the sympathetic nervous system comes from T1 to L2. And here's our sympathetics. Well, T5, T6, T7, T8, and T9 all come together to form the greater splanchnic nerve. Now this is a preganglionic nerve. Now, what I mean by this is here we've got this ganglia where it synapses onto another cell body, and then the nerve coming from that would be postganglionic. So pre just means before, post means after the ganglia. T10 and T11 comes the lesser splanchnic nerve, and then T12 is the least, comes off of that. L1 and L2 come together to form the lumbar splanchnics. So for our sympathetics, we've got greater splanchnic, lesser splanchnic, least splanchnic, and lumbar splanchnic. All of these are splanchnics, but it's important to remember that the pelvic splanchnic is not sympathetic, but it's parasympathetic. Remember, our parasympathetic nervous system is our rest and digest, although our sympathetics are our fight or flight. The greater splanchnic synapses at the celiac ganglia. The lesser and least, they're going to synapse together at the superior mesenteric ganglia. And the lumbar splanchnic is going to synapse at the inferior mesenteric ganglia. Now, if you've started looking at the blood supply, you'll remember two things. So superior mesenteric ganglia and inferior mesenteric, those names sound very familiar. So on our aorta, we've got some arteries coming off. We've got a superior mesenteric artery, and we have an inferior mesenteric artery. So these postganglionic nerves coming off are actually going to go to a plexus located over our aorta. So the superior mesenteric ganglia, those ganglionic nerves are going through this superior mesenteric plexus. So you can sort of see how these are starting to go through. Where our inferior mesenteric ganglia, that nerve, our postganglionic nerve coming off, is going through the inferior mesenteric plexus. The celiac ganglia, the greater splanchnic went into the celiac ganglia, and then the nerve coming off of it that's postganglionic is going through the celiac plexus. The vagus nerve is also traveling through the celiac plexus as well as the superior mesenteric plexus. The pelvic splanchnics, remember that is our other parasympathetic nerve. It's going to go through the hepatic plexus. So, remember earlier we had talked about before that parasympathetics, they've got a long preganglionic nerves, and then they've got short postganglionic fibers. And you can see that here, where with the sympathetics, they've got really short preganglionic before they synapse, and then they've got long postganglionic. And if you remember, when you look in the body, you can see this sympathetic chain, and that is only affecting our sympathetics. These are coming off through the sympathetic chain. The parasympathetics do not go through this, since it is called the sympathetic chain. Okay, so then we've got synapses that go to our guts. So our foregut is going to be composed of our stomach through half of our duodenum. Our midgut is the other half of our duodenum, the second half, to the 2/3 of our transverse colon. Our hindgut is composed of the other third of our transverse colon to our anus. So, our vagus nerve is going to synapse in our foregut, as well as the postganglionic nerve coming from our celiac ganglia. The two nerves coming off of our superior mesenteric ganglia, those postganglionic nerves, are going to synapse in the midgut. Remember, the vagus nerve also synapses there. And then the nerve coming off of our inferior mesenteric ganglia, that postganglionic nerve is going to synapse in the hindgut, as well as our pelvic splanchnic is going to synapse in the hindgut as well. So hopefully if you can go through this over and over again and sort of draw this out, parasympathetic and sympathetic system sort of starts making more sense as far as like what names go to what. Okay, so now we're going to talk about the aorta and all of the arteries coming off of it. So we're going to do so by talking about Aorta Man. So we're going to start out by drawing the eyes, and these are going to be the left and the right inferior phrenic arteries. Now remember, the left and right are flipped because we're looking at our patient. The next thing we're going to draw is our nose, and that's going to be our celiac trunk. Our mouth is going to be the superior mesenteric artery. That's going to be our SMA. If we have an SMA, we're going to have an IMA. So our belly button is our inferior mesenteric artery, IMA. The next thing we're going to draw is our arms. So that's going to be our left renal artery and our right renal artery. Let's draw some nipples on our Aorta Man. So those are going to be our left and right gonadal arteries, and I remember these because I think of sort of the reproductive system. So we've got our breast and also our gonads. Our armpit hair is going to be our lumbar arteries. Then let's draw the legs in. We've got a left and a right common iliac artery. For the bulk of our thigh of our Aorta Man, then we're going to have an external and internal iliac as it splits apart in our pelvis. And so I'm going to abbreviate on the opposite side, but they're also internal and external iliac. And then the last part is like the penis of Aorta Man, and that is the median sacral artery. And that's Aorta Man. And so now you can remember all of the arteries coming off of the aorta in our abdominal aorta, coming off under the diaphragm. And here it is, just for example, so that you can actually see it all drawn out. So as you can see, the IVC, it's called the aortic tango. The IVC travels over the aorta. And so the SMA can actually put pressure and clamp down on that left renal artery. But we're going to talk about that more next week. So this is a recycled slide. It's the esophagus. Remember, the esophagus is between the trachea and the thoracic bodies. It's innervated by the vagus nerve. Remember that the vagus nerve passes behind the lung root, and like we had said earlier today, it is part of the parasympathetic nervous system. There are visceral afferents from the sympathetic that relay pain to the CNS. The blood supply is going to be the thoracic aorta, bronchial arteries, and the left gastric artery. And we're going to talk some more about left gastric today. That's going to come off of our celiac trunk that we had just talked about on Aorta Man. And that's part of our foregut, remember from earlier. So the points of narrowing would be the junction of the esophagus and pharynx, where it's crossed by the arch of the aorta, where it's compressed by the left main bronchus, and at the esophageal hiatus of T10. So there's going to be this thing called the Z-line, and that's between our esophagus to our stomach. It lies at around T11. It's an area where there is squamous cells that transition to simple columnar. The innervation is provided by the esophageal plexus, with the anterior and posterior vagal trunks, which would be parasympathetic, and then also the greater splanchnics, which we had talked about as sympathetic. There can be two types of hernias that are affected near this Z-line. So there is a paraesophageal hernia, and para just means beside. So as you can see in the picture, it's sort of sliding over, but really not moving. That Z-line just stays in the same position. And then you can see a sliding hernia, and so it just slides up past the diaphragm and becomes a problem. So now we're going to talk about the stomach. It's located between the esophagus and the small intestine, and it's called the great food blender. So there are different parts of the stomach. The top of the stomach is called our cardia. The cardia is the part going in from the esophagus to the stomach. Then the upper portion of the stomach itself is the fundus. Then the large portion is the body, and then as we're getting ready to exit, that is our pylorus. So the smaller curvature, which would be at the top, is our lesser curvature, and at the bottom it's a bigger curve, so that's going to be our greater curvature. It's held in place to the gallbladder through the hepatoduodenal ligament. And then the lesser curvature is held by the hepatogastric ligament. In the inferior of the stomach, there are gastric folds called rugae, and they're longitudinal folds of the gastric mucosa. And then they diminish as the stomach is distended. So as our stomach gets bigger, you're not going to see as many folds, which makes sense because it's stretching apart. The gastric canal is the groove that forms between the rugae and then the lesser curvature. In the bottom left, you can see the same picture as shown in the middle, except it's from a different orientation. And so the person is clamping down and holding onto the hepatoduodenal ligament. So now let's go down a little farther and talk about the duodenum. So there are four portions: superior, descending, inferior, or ascending. They're also numbered, so the first part, second part, third part, and fourth part. The first part, or the superior part, is with the pylorus. So we had talked about the pylorus of the stomach. Then there'll be a pyloric sphincter. And then now we're going to come to our superior duodenum. It's going to lack circular folding, which becomes important later because other parts of the duodenum have that circular folding. And it's going to contain or have the bile duct, gastroduodenal artery, and the portal vein passing behind it. And you can see that in the picture. The descending portion has circular folds present, unlike the superior portion, and then the bile and pancreatic ducts open into the duodenal papilla. The inferior portion have circular folds present, and then the superior mesenteric artery passes over it at L3, and you can see that that's what's labeled in the picture. Since the superior mesenteric artery passes over it, if it becomes inflamed or has an aneurysm, then that could press on the inferior duodenum and cause a nutcracker syndrome. And we'll talk more about nutcracker syndromes in later slides. The ascending portion of the duodenum is retroperitoneal, and it ends at the duodenojejunal flexure, and it is supported by the ligament of Treitz. Now, our blood supply actually comes from two places. It comes from gastroduodenal to supraduodenal, and the anterior and posterior superior pancreaticoduodenal arteries. And then from our SMA, the anterior and posterior inferior pancreaticoduodenal arteries. Now we're going to talk more about these arteries in a little bit. So jejunum and ileum, there are some mnemonics to help you remember those, so just Google them and try to find them, ask a friend. They're a little bit inappropriate, so I'm not going to tell you them, but I'm sure that you can find them on your own. But the jejunum has few arcades and long vasa recta, and then the ileum has many arcades and short vasa recta. And the ileum also contains these Peyer's patches, and these are used as an immune function. So make sure that you know in lab as well as lecture that the jejunum has few arcades, long vasa recta, but the ileum has many arcades and short vasa recta. They're kind of opposites, and that's how you can identify jejunum from ileum. So let's talk about the celiac trunk, all of the arteries coming off of it. Remember, we drew it as our nose on our aorta man, and there were three things coming off of it, so we're going to go ahead and draw what's actually coming off. So here is our celiac trunk. So let's change color so we can see all of the different things coming off of it. And the first thing coming off is going to be our left gastric artery. Coming off our left gastric artery, we're going to have esophageal branches, and then we're also going to have gastric branches. So this goes to our esophagus and gastric to our stomach. We're going to draw this curlicue one, which is our splenic artery, and if you look at it in lab, it curls like that, and it throws off a branch, which is our pancreatic branches. Then we have another branch, which is our splenic branches, which of course goes to our spleen. And then also we have our short gastrics going to our stomach. We have another branch off of our splenic artery, and that is going to be our left gastroomental artery. And remember, the left gastroomental comes off of splenic artery. Our next main branch off of the celiac trunk is our common hepatic artery. Our common hepatic throws a branch called our right gastric, and that is going to go and meet up with our left gastric artery. These two arteries get the lesser curvature of the stomach. Then we've got the proper hepatic artery coming off of our common hepatic with a left branch and a right hepatic, so a left and a right hepatic. And then our right branch is going to also have a branch called the cystic artery, which goes to our gallbladder. Coming down from that, we've got our gastroduodenal artery. Gastro, remember, is stomach. Duodenal would be our duodenum. And then from our gastroduodenal, we'll throw a branch called our right gastroomental artery, and that's going to meet up with the left, which came from our splenic. This gets the greater curvature of our stomach. The gastroduodenal also gives a branch called the supraduodenal, so that's going to be the top of our duodenum. And then as it goes down, it's going to give off two more branches. This is our superior anterior pancreaticoduodenal artery. This is going to our pancreas and duodenum. So we have superior, posterior, pancreaticoduodenal. And remember that the superior anterior and superior posterior pancreaticoduodenal arteries, they ultimately came off of the celiac trunk. Because of our SMA, which remember that was our mouth on our aorta man, it's going to throw two more branches that meet up with these superior pancreaticoduodenal arteries. And they're going to be the inferior posterior pancreaticoduodenal artery and inferior anterior pancreaticoduodenal arteries. Okay, so I know this is very complicated, but the more that you draw it out and practice drawing it, and think about in lab, especially knowing things are named based on where they go. So something may not come off exactly where you think it does, like on your picture, but a pancreatic branch is going to go to the pancreas. It's named based where it goes. The splenic artery is going to eventually get to the spleen. The greater curvature of the stomach, if they ask you what artery it is, it would be either, depending on what they pointed to, the left or the right gastroomental artery. And then know what the main branch came off of the celiac trunk. Remember, it's left gastric, splenic, and common hepatic. And then know what arteries come off of those. Here is the complete example of the celiac trunk, and I went ahead and included pictures to remind you of what organs they go to. So besides the two arteries that came off of SMA, and I'll go back just to remind you, it was the inferior posterior and inferior anterior pancreaticoduodenal arteries. Besides those two, there's going to be some more things coming off of SMA, but also some things coming off of IMA. So as you learned this week, you've got portions of your large intestine. There's going to be the cecum, ascending, transverse, and descending colon, as well as the sigmoid out to our rectum and anus. So our SMA is going to give off three more branches, and that's going to be middle colic, right colic, and ileocolic. So the way I remember it is MRI. So middle colic is going to come up and it's going to travel. It's going to travel up and get part of our transverse colon. The right colic is going to go straight across and to the right and get our ascending colon. And then our ileocolic is going to get portions of the small intestine as well as down to our cecum, and it's going to throw off a branch to our appendix called our appendix branch. Our IMA is going to have a left colic. And remember, in our SMA, there was right colic. So IMA is going to have left colic. And then also sigmoid. And that was to our sigmoid colon. Our sigmoid is going to also give a branch down to our superior rectal. The top two portions, which are our like corners, are our splenic flexure on the side of our spleen and then our hepatic flexure on the side of our liver. Now, it's really important to remember, if you can't remember like what goes to what, and you can't remember the mnemonic MRI, you can think, well, there's probably an artery that's going to supply every portion of our large intestine. So we've got something going to the cecum. We're going to have something going to right across to our ascending, something going to transverse, something going over here to descending into sigmoid. And if you go through and can label all of these, you can start figuring out, okay, SMA is going to be MRI, and then IMA is going to be left colic and sigmoid. There are these areas that I circled in purple that are called our watershed regions. So if you notice, there is a left colic and goes down to sigmoid, and then this middle colic comes up to our transverse, but it's super far apart. We've got this marginal artery that travels all the way around to help connect our middle colic to right colic to ileocolic and over to our left colic and sigmoid. And then throws off little branches so our entire colon is supplied. But you can see that there's no major branch going to our splenic flexure, for example. So since there's no direct branch from SMA or IMA to supply regions, it can become ischemic if this marginal artery, for example, is cut off. And if it becomes ischemic, it becomes necrotic, and then it dies. And so the person can actually die from this watershed region, for example, if they got stabbed in the gut or if something happened during surgery. Another part would be between the last sigmoid and superior rectal arteries, and then the other portion is between the ileal branches of the SMA and the ileocolic. So the rectum and anus. So the rectal blood supply, there's going to be a superior, middle, and inferior portion. The superior is coming from our IMA, from our sigmoid, just like we had talked about. The middle comes off of our internal iliac, and then the inferior rectals are coming off of our internal pudendal artery. And you're going to talk more about pudendal in the next block, but for completion's sake, that is what supplies the inferior rectal. So sigmoid is superior rectal, middle comes off of internal iliac, and then inferior comes off of internal pudendal artery. This pectinate line is the area that becomes keratinized stratified squamous below the line. Above this line, it is visceral, where below the line, it's somatic. And hemorrhoids play a major part in this example because external hemorrhoids are going to be painful. They're coming from inferior rectal veins and arteries, which, remember, came off of internal pudendal below the line, and that's somatic. Where our visceral, it's not going to be painful. These internal hemorrhoids coming from superior rectal veins and arteries off of IMA above the line won't hurt as much because of this visceral nervous system. Okay, so let's talk about the liver. on the front, we've got ligaments supporting it. We've got our coronary ligament, and I think of it as being high or sort of like closer to the heart, so coronary. Falciform ligament comes down in between our left and right lobe, and then the ligamentum teres, which is also our round ligament and our obliterated umbilical vein. If you flip the liver over, you can see our other lobes. So we've already talked about our left and our right lobe, but then we also have our caudate lobe, and that's going to be near our IVC, and then our quadrate lobe, and that's going to be near our gallbladder. So I kind of think of it as like IC, and then quadrate and gallbladder are going to be sort of like more farther down in the alphabet. It's not the best way of remembering it, but it's the way I'd remembered it. Falciform ligament right here, as we had talked about on the front, and then that's the end of our ligamentum teres again. Right here between our caudate lobe and our left lobe is going to be the fissure for our ligamentum venosum, which was the remnant of the ductus venosus. In our liver, we've also got this portal triad consisting of our hepatic artery, portal vein, and our biliary duct. And in each of these hepatic cells, bile flows away from the hepatic vein, and that's what's in the center, from our hepatocytes, and blood coming from our veins and our arteries, the blood is traveling toward that hepatic vein. Okay, let's talk about ducts, and we're not talking about these type of ducts. In the liver, the common bile duct is formed from the common hepatic duct from the left and right hepatic ducts. And so here's the common bile duct. Here's the common hepatic duct coming from those right and left hepatic ducts. Connection from the gallbladder to the common bile duct is through our cystic duct. And remember, we had a cystic artery, so it's similar, cystic duct. And remember that the common bile duct is part of the portal triad and transports bile to the duodenum via the sphincter of Oddi. And here is our sphincter of Oddi. Okay, the pancreas. Our pancreas is also posterior to our SMA. The portal vein forms posterior to the neck of the pancreas. And then the pancreas is also behind the stomach. So if we think about, let's say this patient has an ulcer in their stomach, it can affect the pancreas because the pancreas is behind the stomach. The head and the neck of the pancreas is the most common place for cancer. So the portal triad in relationship to the omentum. So the hepatic, we had talked about the hepatic artery, portal vein, and common bile duct. And it's connected to the stomach by the lesser omentum. So here is the hepatoduodenal ligament containing this hepatic artery, portal vein, and common bile duct. Connected to the stomach right here. Here's our portal triad and that ligament. For our last part, we're going to talk about the portocaval anastomosis. So under normal conditions, the portal venous blood is initially processed by the liver, and it drains out of the liver via the hepatic veins and back into the caval system. which is the systemic system, through the inferior vena cava. There's also more communications between the portal and caval system that are a lot smaller. So it's really important when there is a backup, and that's what that we can think of as clinically important. So in the portal system, we've got periumbilical veins, and they meet up with the caval system as epigastric veins. So when there's a problem, this is called caput medusa, which kind of looks, it's like the palm tree sign. It looks like creepy worms almost on the person's stomach. The colic veins, which are right here, they meet up with the caval system as ascending lumbar veins, and we don't have a clinical importance right there. Then we've got the superior rectal veins, and they meet with the middle and inferior rectal veins. That's the caval portion, and it's clinically important as hemorrhoids. The left gastric vein from the portal system meets with the esophageal veins, and when that gets backed up, that can cause esophageal varices. And these are important in portal hypertension. That's all I have today, so I hope that you have learned something. If you have any questions, please email me. Thank you so much. Bye-bye.